think some of the key takeaways is that to increase living donation rates really requires a multidimensional approach. So while financial barriers are absolutely a necessary thing to tackle, they aren't everything. And so some of our uh, some of our other findings find that these kind of concerns and willingness to donate and factors that impact willingness are disproportionately kind of distributed across different racial and ethnic groups as well as by sex. And but addressing financial concerns are not sufficient on their own. So programs integrating kind of culturally tailored education, patient focused, and family centered uh, education and discussions that allow uh, patients to navigate these discussions with potential donors, as well as ensuring that donors have better ways to navigate donation services, proactively discussing medical concerns as well as other concerns about the process. Specifically for communities that historically experience disparities in transplant access, it's especially important to address concerns around risks and long-term health transparency uh, and health transparently. Um, Again, clinicians and transplant centers should also really work on tracking like who starts and completes donor evaluations and how these are stratified across different groups, which will allow transplant programs to identify where drop-offs occur and to tailor interventions accordingly. Ultimately combining structural support with relationally grounded and culturally responsive counseling is probably the better way to increase living donation rather than addressing just financial concerns. Financial and socioeconomic factors definitely influence donation rates and access to care in both like visible and subtle ways. So, um, medical costs, or even when medical costs are covered, potential donors often face these indirect expenses that are disproportionately borne by lower socioeconomic individuals if they miss a lot of work. So things like lost wages, childcare, travel to and from appointments, lodging, and taking time away from work that's much harder to do when you, especially when you're working kind of a day-to-day job and less an hourly job where you're relying on having those hours in the work. So for individuals without paid leave or flexible employment, it can represent a significant hardship. Um, and like I said, these burdens are not evenly distributed. Financial concerns were more commonly reported among Black and Hispanic individuals, reflecting kind of broader structural inequalities. Um, so navigating these indirect costs as well as medical costs can really decrease people's ability to donate. Um, and we've also seen um, kind of the indirect financial impact, but also when we think about access to care, we see um, it in one of our other recent papers, we see kind of the um, sequence of kidney replacement therapies are different across racial and ethnic groups, with Black and African American patients spending much more time on dialysis uh, compared to white Americans and white patients. So we see that while the burden and the cost may disproportionately fall on other low SES individuals, we also see that kind of sequences across racial and ethnic groups in the US are not evenly distributed or not equal. Um, so very I mean, with that, you just access to care, and we see much lower rates of kind of referral for donation for among Black and African American patients. We see many more patients, Black and African American patients, on dialysis compared to receiving transplants. So kind of access to care and treatments are not equally distributed across groups.